It is a great honor to present the original article accepted on the Korean Journal of Radiology. This article is about the pre-operative perfusion skewness and kurtosis. As you know, the prognosis of the patient with glioblastoma remains poor, with a median survival time after diagnosis of about 12 months. As multimodal aggressive treatment has been investigated, it has become increasingly important to identify early indicators of progression. Currently, efforts are focused on identifying imaging biomarkers that may affect the therapeutic choices and patient outcomes. For example, dynamic susceptibility contrast MR imaging provide a means of characterizing tumor biology, with the measurement of normal cerebral blood volume being the most widely used hemodynamic variable derived from the SCMR perfusion imaging. Indeed, NCBV has been found to correlate with glioblastoma grading and tumor microvasculature density. Histogram analysis of NCBV has been found effective for glioma grading by reflecting the heterogeneous morphology of high-grade glioma vascularity. Compared with the hotspot method, histogram analysis has been shown higher inter-observer agreement and comparable diagnostic accuracy. Survival has been analyzed rather than diagnostic accuracy with respect to glioma grade. Because histopathologic determination of glioma grade from tissue samples has inherent limitations, including small samples, inaccurate tissue sampling, inaccessibility, and subjective grading criteria. We hypothesized that statistical parameters derived from the NCBV histogram could be used to stratify survival in patients with glioblastoma. Skewness and kurtosis has been used to compare histogram shapes. We retrospectively determine whether skewness and kurtosis from semi-quantitative histogram analysis of NCBV in entire contrast-enhanced lesions could predict progression-free survival in patients with partially resected newly diagnosed with glioblastoma. The median records an MR imaging result of 272 patients with histologically confirmed glioblastoma based on examination of tissue samples obtained via stereotactic biopsy or particular resection from March 2006 to May 2014 were retrospectively reviewed. Of these, 102 patients with complete tumor resection before concurrent chemotherapy were excluded. 50 patients who had steroid administration at time of the MR perfusion imaging were also excluded. In the remaining 150 patients, 12 patients who showed significant motion artifact were excluded and 8 were excluded due to the lack of pathologic diagnosis. Finally, 135 consecutive patients were enrolled according to the following inclusion criteria. This slide shows the detail of the conventional and dynamic susceptibility weighted contrast enhanced MR imaging. MR imaging data were transferred, perfusion parametric maps were obtained using dedicated software package. A relative CVV map was generated using established tracer kinetic model applied to the first pass data. After several steps, the NCVV map was displayed as a color overlay on the post-contrast T1 weighted image. Since histograms derived from the NCBV were often bimodal or skewed, we used two mixture normal distribution to provide optimal fitting. The histogram pattern for each group were evaluated statistically for skewness and kurtosis, as well as for mean and range. Skewness is the measure of the degree of asymmetry of a distribution. A negative skewness indicates an elongated tail on the left side of the mean, with most values lying to the right of the mean. The positive skewness indicates an elongated tail on the right side of the mean, with most values lying to the left of the mean. Kurtosis is the degree of the peaking of a distribution, indicative of the relative CVB value of the maximum frequency. There are 4 groups according to the combination of skewness and kurtosis. Progression-free survival and overall survival were analyzed by Kaplan-Meier method, with the groups compared by two-sided log rank statistics. Cox proportional hazard regression were performed to assess the effects of patient age, sex, resectability, KPS, tumor size, skewness, kurtosis, and mean NCVV on progression-free survival and overall survival. Patients who remained alive at the analysis were censored on the date of the last follow-up visit. A p-value less than 0.05 was considered statistically significant. 135 tumors investigated, 22 were classified as Group 1, 58 as Group 2, 29 as Group 3, and 26 as Group 4. Figure 1 to 3 shows example of glioblastoma histogram pattern. The mean time for post-processing of an MR perfusion histogram was 7 minutes and 22 seconds. The base level of kurtosis was 3. This shows the example of Group 1, positive skewness and leptokurtosis. This shows the example of Group 3, negative skewness and leptokurtosis. This shows the example of Group 4, negative skewness and platykurtosis. The Kaplan-Meier curve of progression-free survival for the 4 histogram patterns are shown in the figure 4a. Mean time to progression of the groups 1, 2, 3, and 4 were 62, 51, 39, and 41 weeks, respectively. Log rank tests showed that patients having tumors with positive skewness and leptokurtosis had a significantly longer time to progression than did those with negative skewness and platykurtosis. Of the 135 patients, 27 were progression-free at the time of the evaluation, a mean of 45.1 weeks after diagnosis. When the Kaplan-Meier curves and log rank tests were used to evaluate the association of the histogram patterns with overall survival, we found that the differences are not statistically significant, although the patient with tumor having positive skewness and leptokurtosis tend to have a longer overall survival. This slide shows the Kaplan-Meier survival curves of the patient stratified by perfusion, skewness, and kurtosis. P-value from the Cox proportional hazard ratio indicate that histogram patterns, resectability, and KPS were independent predictors of this progression, whereas age, sex, mean NCVB, and tumor size were not. The KPS was significantly independent predictor of overall survival. We have shown that both skewness and kurtosis derived from the NCVB histogram can predict the mean time to progression in the patient with partially resected newly diagnosed glioblastoma. Glioblastoma was negative skewness and platykurtosis showed a significantly more rapid time to progression than those with positive skewness and leptokurtosis. A longer time to progression was associated with most NCVB value being lower and the shape of the histogram being narrower and more peaked, reflecting more homogeneous tumor composition. Although we found the histogram pattern could predict the progression-free survivors, we observed no correlation between histogram pattern and overall survival. Many clinical, surgical, and therapeutic associated factors may affect overall survival. In addition, the censoring of 36 patients may have affected the true overall survival. We found the tumors that progressed more slowly has significantly lower means and smaller range of NCBB histogram. These findings are in accordance with the result showing that higher number fractions were associated with higher peak heights and wide range. These results may be due to heterogeneous expression of aggressive cellular features. Broadly elevated microvascular density has been shown to correlate with elevated tumor cellularity, malignant progression, and extensive tumor invasiveness, resulting in poor prognostic outcome. Several studies investigate prognostic value of tumor CVV on survival in patients with glioma has shown the correlation between the tumor CVV and patient outcomes. Those studies, however, used median CVV, maximum CVV, or ROI-based techniques of the relative CVV measurement, and therefore did not assess the heterogeneous perfusion characteristics of the high-grade glioma. This study has several limitations. First, the sample size of each group were different. Although overall survival tended to longer in group 1, the differences was not statistically significant, perhaps due to the small number of patients in this group. Or even small size may have strengthened the statistical power of the finding. Second, it was challenging to define entire tumor volume using the histogram method because the glioma are infiltrating tumor with an indistinct border beyond the radiologic margins. However, results from the previous study show that among observers caused by imperfect tumor delineation are relatively unimportant, given the large number of data points included in each histogram. Lastly, since the complete resected tumor seems to be not reasonable for the preoperative tumor perfusion evaluation, we enrolled only the patient with residual tumor after biopsy or partial resection. Moreover, preoperative tumor perfusion evaluating using DSC-MR imaging is more appropriate than postoperative study because DSC-MR imaging could be sensitive to susceptibility artifacts associated with the postoperative hemorrhage or surgical material. In conclusion, histogram analysis of NCVV could be a useful object diagnostic tool to predict time to progression in patients with partially resected newly diagnosed glioblastoma, with the combination of skewness and kurtosis being a significant parameter. Further optimization and improvement in post-processing of this semi-quantitative method may affect treatment plan and clinical outcome in patients with glioblastoma. Thank you for your attention.